Welcome everyone, and I'm really sorry about that. We had a bit of a technical glitch here in Durban, but we seem to be back on track right now. We got this wonderful concept called load shedding here, and we've had some bad weather of late, but fortunately the IT guy has been with me and he's assisted me in getting everything going. So I would like to welcome all of you, and thank you, Maxine, for this opportunity to address the allium community once more. This is one of my pet sort of likes and my passions here in South Africa, sort of dealing with these allium stents and the minimally invasive forms of management of urinary tract obstructions. So today we're going to go through the minimally invasive methods for treating lower urinary tract obstructions, particularly with the allium OPS stents. And I'm going to share with you some of my South African experience. We have a unique variety of pathologies here in South Africa. And yeah, we're going to just touch on what we sort of do down here. Okay, so just by way of introduction, I'm from the east coast of South Africa, from Durban. It's an amazing city, beautiful place. If ever you guys are down here, pay us a visit. We're quite friendly people, and we enjoy hosting people, as Maxime will attest to. He spent a week with us about a year ago, and I think he thoroughly enjoyed himself. I know if you guys know Cape Town, and all the attraction that Cape Town offers, but yeah, Cape Town is just nice to look at. The beaches, unfortunately, are sort of only viable probably about 2 weeks in the year. Durban's got 365 days of summer. All right, I enjoy cycling, enjoy a bit of running, play a bit of cricket. I'm married with two wonderful kids. Well, I should say kids, more like precocious adults. And that's my beautiful wife. She's in the medical field and happens to be a pulmonologist. Okay, enough of me. So with regards to our topic today, I think most of us that are on are either urologists or people associated with this industry. And, I think we're all sort of familiar with the fact that urinary tract obstructions are quite common, both the upper and lower obstructions. This forms the bulk of our work as urologists. And admittedly, the endoscopic management of these obstructions has revolutionized the management of urinary tract obstructions. The question, though, is do we have to always open a patient when endoscopic treatment is not sufficient for the disease process in front of us? And what if I told you there was an easier way? Historically, the management endoscopically was more like putting a finger on the dike. We sort of would offer the patient a temporary solution, but we kind of accepted that the stricture would recur both in the upper and lower urinary tract. And that's where I want to jump straight into the topic, the allium stents, and introduce this to the community, especially those of you who aren't familiar with these stents. So these stents, they've been on the market for a while now. And well, at that stage when they were introduced, they were quite novel. They're self-expanding stents. So they go in, basically put it simply, they go in narrow and then they expand within the patient. They consist of a core of nitinol nitinol scaffolding, which gives these stents their tensile strength. And the body is predominantly made up of a polyurethane silicone copolymer, which allows these stents to be sort of more comfortable than the traditional full metal stents, and more biocompatible rather, and more flexible. So it's more comfortable for the patient. There's a wide variety of stents across the urinary tract that's made by the manufacturers. And, unlike the traditional endoscopic management where we cut open a stricture and in the upper urinary tract would leave a JJ stent, or in the lower urinary tract, a catheter temporarily, these stents offer us definitive stricture management, and they're not a temporary solution. The success rates, depending on the series that we look at, are comparable to the open procedures meant to treat these disease processes. And again, depending on the series we look at, the quoted success rates are anywhere between about 80% to 90%. Importantly, they offer us a viable, minimally invasive treatment option in a well-selected patient. So if you look at these stents and ask ourselves, why are these stents a dream come true? I think let's just break it down into the benefits, both to the patient and to the surgeon. If you look at the benefit to the patient, the outcomes are good. They're fairly well tolerated. It prevents the patient from having to undergo recurrent procedures. And I mean, I think for you urologists here, if you can think of patients who have been in your practice with urethral strictures who've been managed by internal urethrotomies, I think you realize that, as much as you get good flow rates and it's a minimally invasive treatment option, urethrotomies tend to sort of lead to subsequent urethrotomies, and these patients tend to have frequent procedures. Here we're offering the patient a definitive stricture management solution. There's way less morbidity than the concomitant open procedure necessary to treat these obstructions. Importantly for the patient as well, there's a much quicker return to function. And here in South Africa, this is an important factor with less loss of income. So the patients are functional almost immediately. In South Africa, these stents are covered in full by our medical aids or our insurers. So the cost to the patient is minimal to almost nothing. These are patients who are on medical insurance. And importantly, if you look at the benefit to us as surgeons, again, the outcomes are good. It's a much shorter procedure than the open procedures necessary to treat these conditions. There's a lot less post-operative care. I mean, I think if you use the example of the urethroplasty, these patients will stay in hospital for days, possibly have a catheter in for a few days as well, sort of come back for subsequent follow-ups and then have the catheter removed. The post-operative care here is sort of much less involved than with the open procedures. Also, I think we're all familiar with the fact that open procedures can be risky and time-consuming. And, a minimally invasive treatment option which offers us definitive stricture management allows more efficient utilization of our theater time, which here in South Africa also is a bit of a premium given our large backlogs, especially in the public sector. For the private healthcare urologists in South Africa, important point is that, although not a significant factor, but importantly, the remuneration to the surgeon has been negotiated to be comparable to the concomitant open procedure, obviously with a fraction of the effort and risk. So we're going to just basically go through a background of these stents. We're going to look at the indications and the outcomes, and I'm going to share some of my experience. If we look at the stent options for the lower urinary tract, they're all basically inserted using the one platform system, which I'm going to shorten to OPS for the purposes of this conversation. The OPS, basically, it's a straightforward device. It resembles a cystoscopy. The stent is crimped at the distal end of the device. And basically, the purpose of, or the trick here is to release the stent off your delivery device and allow your delivery device to pass through the stent as your stent expands. There's an irrigation port, a port for the insertion of the optical element, your safety lock button, and your trigger mechanism. Okay, basically in theater, we'll require good flow. It's important for novices and first-timers to realize and appreciate that the flow through the one platform system delivery device is not as great as it is through the cystoscope, so your vision may be impaired. And the reason I'm going to highlight that is because when you're doing your optic ureterotomy, try to minimize bleeding. So cut until the point of bleeding, but try not to cut a single incision too deep to the point where you get excessive bleeding. All right, a few pre-procedure considerations. I think patient selection is very important. Also, you got to educate your patient well before you insert these stents as well. And by education, I think you should inform the patient that they're going to have a foreign body implanted into their bulbar urethra. It is normal to have a bit of perineal pain. That perineal pain can last anything from 2 to 4 weeks. A patient who's not well informed and is not sort of, set up for that kind of expectation could come back to you within that period and actually force your hand into removing the stents. And, I've helped colleagues in other countries who've been in that position. We try to make ourselves, I wouldn't say unavailable, but our first scheduled appointment after insertion of these stents is usually after 4 weeks, after we've informed the patients that you're going to have a little bit of discomfort initially. All right, and it's also important to gauge what your patient expectation from these procedures are. The potential adverse events are a little bit of which we've gone through, and clearly some hematuria as well. Importantly, immediately after implantation of these stents, there's an immediate improvement in the relief of urine flow. Okay, very basic stuff's needed in theater. I use a cold knife to address the stricture. Although the experts in the sort of, the other sort of allium sort of, or the guys in the allium community say the X-ray is not a must in theater. This has become my preference. It's become my preference so I can outline the stricture. I can insert contrast prior to the optic, and I insert contrast once I've inserted the stent to demonstrate that I've got good patency within the stent, which I keep in the file to show the patient. I feel like it's important that you actually have good documentation. So although it's not an absolute prerequisite, I think it just adds to your documentation and it's a good practice. Okay, and basically you'd need a basic optic element. Can be performed under local anesthetic, a measuring device, and a pressure sort of bag. Okay, so that's basically what the BUS stent looks like. It's basically a copolymer surrounded by nitinol scaffolding. All right, and the indications for the bulbar urethral stent is bulbar urethral stenosis. These stents can be considered as an alternative to or bridging to urethroplasty. And importantly, we mentioned that it prevents recurrent urethrotomies. Importantly, the stents are meant to remain in for a maximum of 3 years, at which stage they should be removed. My preference is to leave these stents in for a year for several reasons. One is, and looking at the sort of series amongst the international community, I think most people sort of do this because after a year, it seems like we get good stricture management and adequate contraction of the fibrous tissue. The other thing is, or the other reason why I prefer not to leave it in for 3 years and keep my maximum indwelling time at 1 year is we have a little bit of a unique problem in South Africa with patient compliance. So I'm a little worried that if I tell the patient, we're going to remove it after 3 years, that patient could potentially be lost to follow up, especially if they're doing well as well. And then you're dealing with the sequelae of complications of a stent that's been in for too long. Okay, these stents basically come in 3 sizes or 3 lengths, a 50, a 60, and an 80 millimeter. And the 80 millimeter has a reverse component. By that I mean that the tapered component, which is usually proximally, is flipped around and is now distally. And the portion that you implant proximally would be the maximum sort of diameter of the stent, which is up to 45 French. I'll go through this later, but this has actually become my preference, the reverse BUS stent. Importantly, the BUS stents don't have an anchor, unlike the prostatic and the round posterior stents and triangular prostatic stents. Okay, the correct stent size that you choose would depend on, I think the first thing that you should bear in mind here is your level of experience and also your preference for stents as well. But the things that you should take into mind are the stricture length and the distance from the sphincter. Find your own way to address these strictures. I cut with a cold knife. It's relatively inexpensive. I get good results with that. And I find that if you do it at more than one site, and I often utilize the Mercedes-Benz incision technique to open up to at least 28 French, I'm able to open up the stricture without getting too much bleeding. But I think the one thing I'm going to caution against is, again, avoid cutting a single incision too deep into the mucosa to the point where you get bleeding. All right, so this is a video that was sent to me from Maxime. That's basically a stent that's been implanted. And yeah, the criticism I would have here is that there's a bit of bleeding, and you've implanted the stent into a little bit of a bloody field. Still a good implantation. You can see there's adequate coverage of that stricture. I try as far as possible not to do that. I also find that the bleeding can increase your risk of migration. Fortunately, our vision here seems to be okay. That's the other issue with bleeding through that as well. Okay, so just to share one of my cases, the first patient was a 37-year-old male who had recurrent STI-related urethrotomies. He was stricturing or restricturing frequently and presented to me with a tight bulbous stricture. He had undergone an optic 2 weeks prior to the video I'm going to show you. Okay, so that's basically what a stricture looked like at initial presentation. Okay, I'm just going to highlight how I do the optic here. This is wide open at this stage, but basically what I do is I make a single incision at 12 o'clock, and then I gauge as to whether the diameter of the lumen is sufficient. If I can get my scope through it and it's up to 28 French, I'm happy. If I can't, then in a subsequent video, I'll show that. I turn my scope around and make 2 further incisions at 5 and 7 o'clock. Okay, and this is the important part, the stent deployment. This is done with the OPS delivery device. And here I'm going into the OPS device, and it's always a pleasure when there's no bleeding, because remember the irrigation here is not as sort of great as through the cystoscope itself. I'm heading towards the bladder. There I'm at the sphincter. All right, so what I do is, and this is with the reverse BUS, I just deployed the stent there. So I'm at the level of the sphincter, make sure the sphincter is sort of closed, and just proximal to the sphincter, about a millimeter from the sphincter, I deploy my BUS device. Okay, and there you can see it. So I'm basically on X-ray, I'm at the sphincter. And again, it's a habit that I've gotten into to do it with X-ray. You can see the wasting of the stent around the stricture here. And this is my delivery device. That's what I'm looking at, basically. You got to leave it in for 5 minutes. I don't often do that. I think people who've been in theater with me will attest to that, but leave it in sufficiently. I'm going to go back to my X-ray right now. And I think with a bit of experience, and I'm not sure if any of the allium experts are on at the moment as well, but with a bit of experience, you get an idea as to when the stent's ready to come out. And what I usually do is I wait for detachment of the stent from the delivery device, which you can sort of visualize here with X-ray. Yeah, I thought I was a bit impetuous and a bit hasty, and I joined colleagues last year at Coachella University, excellent guys who implanted hundreds, if not thousands, of these stents. And they were a lot more impulsive and a lot more impatient than me. And they implanted the stents, and the devices were out within seconds. What good result as well. So the point I'm making is that Maxime will tell you wait 5 minutes. I think do that when you're starting off, but get into your own routine as to how long you're going to wait. Okay, this is probably the most important part of the stent implantation, the removal of the delivery device. And you do this with rocking semicircular motion. And what you want to see is exactly what we're seeing right now. Your delivery device coming through the stent. So the stent needs to remain in place. If you do this too soon, or if you don't separate the stent from the delivery device without using adequate semicircular motion, you're going to pull the stent and waste the device. So I think just be very cautious with the removal. That can be the trickiest part. Okay, and that's the distal portion of the stent sitting there. That stent was in good position. There's my on-table urethrogram. And you can see that's a fantastic result. Strictures wide open. That's where our wasting was, if you remember. Our sphincter here is closed. And this patient did very well. The stent was subsequently removed after a year. He's at 3 years follow-up right now, and he's had no further issues. Okay, that's a picture of my stent against the sphincter. I highlighted this to show you that you can, with the reverse BUS, get very close to the sphincter and maintain continence. Go through a few tips and tricks a little later. It's really not a train smash if you find that your stent's a little high. You can do one of two things. You can either pull it back, and we'll go through how you do that, or in a few instances, I put the patient on Kegel exercises, and that kind of kicked the stent into the right place where they were continent again. Okay, the second patient was another interesting case as well. This guy was 65 years old at the time, and he had multiple strictures within the bulbar urethra post-brachytherapy. He had a tight, long segment bulbar urethral stricture when I saw him, about 4 centimeters, and he had undergone multiple ureterotomies. He had seen many other urologists before he came and saw me. And you can see there, he's got reflux into the Cowper's glands at a point as well. So this is a long-standing stricture. His bladder was markedly tuberculated. Very unhappy chap. So this stricture was quite a mess to deal with, and the optic ureterotomy was not the prettiest one, but quite successful. And you can see here, I'm cutting at 12 o'clock, and yeah, it's opening up the lumen, but not fantastically. That's a typical cotton wool sort of sign that you see, and my stricture here and my optic as well, admittedly, does look like a bit of the dog's breakfast. But I think the trick is not to lose your lumen and to maintain patency of that lumen. What I'm doing here is I realize that I'm probably getting nowhere with a single incision, so I turn my scope, turn my cold knife, and I make 2 further incisions, one at 5 o'clock and one at 7 o'clock. And okay, I'm going to cut short this video and move on. But yeah, you got to believe me when I say we open it up sufficiently. Okay, so I passed the guide wire at some stage just to make sure, because that sort of, the stricture was just so vast that yeah, I wasn't happy with the lumen. I was concerned that I may just lose the lumen. So I passed the guide wire to continue my cutting and dilatation. And eventually I got it wide open, at which stage I decided to implant the BUS. And you can see here, this wasn't the easiest one to sort of, insert. And there's multiple sort of wastings of the stent, unlike that first patient who was fairly straightforward. Okay, and this is my removal. And again, in the distance, you can see my sphincter, which is intact. The sphincter is closed. This guy was continent at the end of the procedure. And very unlike me, I'm going very slowly through this, clearly because he had multiple strictures and I didn't want the stent to snag on the delivery device at any stage. Yeah, and eventually we got the delivery device out without any hassle. So I think you also got to, yeah, as much as you can put it out quickly, you got to pick your battles, and you got to respect the anatomy and respect the case. Okay, so that was the picture of the stent against the sphincter. That was a picture post implantation of the stent. And here's my retrograde. Again, kept this picture in his file. You can see the sphincter. That's the sphincter here. That's the prostatic urethra there. But the sphincter was closed. A little bit of wasting here, but upon removal, this guy did fairly well. He's also at 3 years follow-up at the moment. His flow rates are starting to slow down a bit, but nothing that's too bothersome. So I haven't embarked upon repeating his uretrogram. I mean, I think at this stage he's pretty happy and his post voids are minimal. But I think if he sort of carries on slowing down his rates, and at some stage I'll have a look because, with brachytherapy and with radiation on board, there's always a possibility that he could restricture at some stage. Okay, two very interesting articles, and I'm going to highlight this. And again, sorry, I got on quite late, so I didn't get a chance to notice who the attendees are. But this was fantastic and groundbreaking work done by a very respected colleague of ours in the allium community, Gio Moon, who I've had the privilege of meeting on a few occasions and working closely with. Very humble, grounded, down-to-earth man. And he and his team rather, in Korea, introduced the concept of a TUR of the fibrous tissue, which makes absolute sense given that the fibrous tissue is the one that is a bit that recurs and gives and leads to recurrent restrictioning. So he basically did a TUR of the fibrous tissue down to the healthy tissue within the mucosa and implanted allium stents. And well, he ran a trial with allium against Mammalocat, but I'm going to talk specifically about allium. And he noticed that with his combined procedure of a TUR and implantation of the allium device, and I noticed that he also removed his stent after a year. He got an 81% success rate with these allium stents. His urethral patency after a year was 81%, which is fantastic. All right.
Within 1 year after the stent removal, Dr. Atkinson, which means we healed the stricture. I think this is important to mention. The success criteria was healing. Yeah.
Yeah, absolutely. Yeah, sorry. Yeah, as Maxime said as well. So it's he noticed 81%. Yeah, so the recurrence rate basically was down low. And I mean, this is pretty close to our urethroplasty series as well. So it's important to bear in mind as well. And, it's something that sort of I've looked at and, that patient that I highlighted was done years ago. But an interesting way to sort of address these, strictures. And possibly, I think when faced with a patient like that with a long segment fibrous stricture, I would consider, a TUR of that before implantation. But like as Maxime said, so it's a durable option. 1 year post removal of the stent, he's got good patency rates. Okay, the Coachelli group, they looked at the long-term follow-up after stent removal. And fantastic guys. Met all of them, worked with them a year ago. Maxime was there as well. Maxime, you recall that?
We've been together
you recall
there.
That? Yeah. Yes. Yeah. So they also noticed that there was an 81% success rate with long-term follow-up of these patients. So the important thing is that these stents have been shown not just to sort of treat these strictures, but also to be a durable treatment option with follow-ups. The stricture hasn't recurred, and it gives you a stricture treatment management option, and not just a a temporary solution to a stricture. Okay, I'm going to move on from urethral strictures and just talk about two more stents that we use in the lower urinary tract. And the triangular prostatic stent and the round posterior stents have become probably my pet favorites in urology at the moment. And I think these are probably underutilized stents, especially the triangular prostatic stent. If you look at the anatomy of the prostatic urethra and we look at BPH itself, I think we all sort of realize that, clearly urinary retention from BPH is from an occlusive prostate. Occasionally you get detrusor decompensation with sort of, poor outlet or poor out or emptying contractility of the bladder. But in patients with a maintained detrusor, it's often due to sort of the occlusion of the lobes. And we're frequently faced with patients who aren't fit for an invasive procedure. And, the reflex is often to put in a suprapubic catheter or just confine them to a urethral catheter. And this is probably where we should be looking at minimally invasive options a bit more frequently. We can offer these patients quality of life, as opposed to sort of just condemning them to sort of reflex catheterization. And if you look at where these stents would fit in and the way I've worked out sort of the indications for myself, firstly, they can be a bridge to more aggressive surgery instead of keeping a catheter in. I think we know catheters are fairly uncomfortable. And it allows the patients to sort of void normally whilst awaiting their definitive procedure. And this is, often seen in the public sector where there's long waiting lists. And these stents can be implanted in the rooms under local anesthetic, and then it's okay if the patient has to wait 2 years for his HoLEP or his TURP. Clearly, the sort of, and where these stents would find their niche would be the patients who are high risk for surgery. Also, it's important. I think it's important to keep it as an intraoperative tool for management of BPH. You know, you can infrequently would find a patient, or maybe frequently find a patient, where you go in and you have a look, and you know, you sort of have a look and you realize that, you know, either this prostate's too big, or maybe it's too small, or, you know, and you sometimes question yourself, like, should I be doing a TURP? You haven't lost anything by, you know, putting in a stent, provided you've adequately counseled your patient preoperatively, you know, allowing the patient to void and then sort of revisiting that. The triangular prostatic stent is a device that's meant to remain in for 3 years, at which stage it means it needs to be replaced. Often the patient population that we use it in are usually the high-risk patients. And, you know, I've never had the opportunity where I've had to replace it, because most patients demise with the stent in. And, you know, the purpose of this exercise is to give patients quality of life, sort of, you know, in their terminal years. All right, so if you look at the specifications of these stents, so very simply, they're triangular, and they're triangular because the anatomy of the prostatic urethra is triangular and not round. It has an anchor which sits in the bulbar urethra, and a transsphincteric component which goes through the sphincter. All right, that's just basically the wire, which, and if you look at it here, the stent itself sits within the lumen of the prostate up to the verumontanum. The sphincteric portion goes through the sphincter, maintains continence because it's just a wire going through, and the anchor sits in the bulbar urethra. Purpose of the anchor, fairly straightforward, prevents the stent from migrating upwards and possibly downwards, I would suppose. Okay, to implant these stents, you have to measure the length from the bladder neck to verumontanum, and you deliver your own way, or rather develop your own way of doing it. I use the markings in the cystoscope, but you can use a urethral catheter as well. Once you've got the marking, then you decide on the appropriate stent placement. You can project about 5 millimeters into the bladder itself without occluding the ureteric orifices. So if the measurement is 4 centimeters, that's pretty straightforward. You'd use a 40 millimeter stent. Clearly not a 50, because then you're going to have too much of redundant stent, and it's going to be uncomfortable for the patient, and potentially you could occlude. If the measurement is 3.5 centimeters, don't use the 30. Use the 40 and protrude 5 millimeters into the bladder neck. The smallest stent's not going to give you adequate cover of the bladder neck, and you run the risk of the patient remaining in retention or having difficulty voiding. All right. Yeah, and I enjoy putting this slide up whenever I give a talk on BPH in the stents. And I think this is absolutely true as well. The management of BPH in this day and age has become the modern day Tower of Babel. You know, we as professionals and as urologists, we tend to be speaking through each other, at each other, sort of, you know, screaming a different language, but very seldom do we seem to be talking to each other. You know, we have set guidelines for the management of BPH, but, you know, it's one of those conditions where there are numerous treatment options, you know, both traditional treatment options, minimally invasive treatment options. Patient choice dictates also sort of, you know, and by choice, I mean patient's acceptance of side effects of a certain surgical protocol often dictates our sort of hand and or dictates our management of this condition as well. You know, I often use this example when I speak to sort of registrars and colleagues down here as well, that, you know, you could or you could take 10 patients with BPH and they could visit 10 different urologists, so, you know, and we'll come back with probably 100 different options. Right, so yeah, it's a condition where we've got set guidelines, and ultimately we all want our patient to void well at the end of it. You know, and how we get there, I think it's sort of a unique you know, decision that is made between the specialist and the patient as well. So coming back and drawing the conversation back to what we should be talking about, the TPS, when should we consider this? It's important that we keep it as an intraoperative option. An indication, probably a bit of a brazen indication, is a young patient who is not willing to undergo an aggressive surgery at this point in time, but obviously wants to void well. The benefit of the stent is that you haven't lost anything. You remove the stent, the patient goes back to his former baseline. The poor anesthetic risk patient we've spoken about. Importantly as well, and I've done this previously or recently as well, in the cardiac patient who has been on blood thinners. I've done it in a patient who's been on Brilinta pretty soon, and we stopped their blood thinners temporarily for the procedure, but we put them back on their blood thinners after the stent has been implanted. And I haven't had significant hematuria. Had some minor sort of episodes of rosé urine, but we encourage the patient to increase their fluid intake, and they've done fairly well. Importantly, post-brachytherapy, and I think, you know, those of you perform high volume brachytherapy. I mean, we just did one this morning and we spoke to the patient. If your patient goes into retention after brachytherapy, there's very little you can do in terms of aggressive surgery. There's clearly a TURP's off the table, lasers off the table. You clearly can't offer the patient an open prostatectomy. The priority at this stage is to allow the seeds to kill the cancer, and any form of treatment here is going to alter your dosimetry and impact on your cancer treatment. So traditionally, the teaching was either put in a suprapubic or put in a urethral catheter and just let the seeds do its job, kill off the cancer, and give the patient at least minimum 9 months, but sometimes up to 12 to 18 months, depending on their PSAs. And at that stage, you can go ahead and you can just obstruct the patient. But we don't have to do that anymore. We've got stents these days, and you can implant a stent safely without significantly affecting the dosimetry. The oncologists aren't too unhappy with that, and give the patient an opportunity and an opportunity to void as naturally and as spontaneously as possible. All right, I'm going to skip the slide. Okay, this was a very interesting patient that I did. Interesting because he's 94 years old, and traditionally I would have put in a suprapubic catheter, but he was a fit 94-year-old, and he wanted to take a shot at voiding.
Sorry,
Yes.
just if you can slide back for a second for the brachytherapy.
Yes.
So what are the downsides of placing the stent while doing brachytherapy process?
Is it Shay?
Yeah. Hi.
Hey, how's it, Shay? How are you?
Fine, thank you.
All right, good hearing from you again.
Yeah,
so are you asking me, would we consider doing this simultaneously with brachytherapy?
My question is, how common is to have a problem in the urethra or in the prostate urethra while having the cancer of the prostate, and
okay,
how common is that? So
Shay,
most of them are with
right
catheters.
So as a urologist, we identify those patients who are at high risk for retention post brachytherapy, and those patients are offered a disobstruction procedure prior to the brachytherapy. So those patients are either TUR, well, they've had a TURP, and it's often it's not a fantastic, significant TURP. We leave a little bit of tissue, a bit more tissue than we would normally for implantation of the seeds. Okay, but so in the patients who we don't think are at risk for retention, we go ahead and we do the brachytherapy. Okay, at least 15% of patients in both categories will go into retention post brachytherapy, and it's an unanticipated retention. So, the patients who are at high risk for retention are weeded out at the inception. We wouldn't allow them to have the brachytherapy until we've dealt with the prostate. But some people, unfortunately, despite all your parameters, your assessments, your measurements, will go into retention. That's unfortunately the nature of medicine. It's not an absolute science. So at least about 15% of people will go into retention. I'm not sure if that's what you're asking me or that answers your question. So
I'm trying to understand. So normally what we say for prostate, for the TPS, that we will use it for BPH. But you are talking about prostate cancer patients that might be.
So I'm not talking. So Shay, make the distinction here. I'm talking about the prostate cancer patient who has had brachytherapy, who goes into unanticipated urinary retention following the procedure.
Yeah.
So that's in that patient, should he have refractory retention following brachytherapy, the traditional teaching was that you would leave a catheter and address that retention after a minimum period of 9 months when the brachytherapy has addressed the cancer and it's safe for you to do so from a cancer perspective. So, I think we're crossing, and remember, benign prostatic hyperplasia, cancer, what we should be talking about rather than saying BPH versus cancer is bladder outlet obstruction from an obstructing prostate. Point I'm making is that the TPS is a viable treatment option for retention following brachytherapy. You don't have to leave in a catheter. It's an option. And there are other stent options as well. I mean, it's not just the TPS. There are other minimally invasive stents that are coming out as well.
Why can't you do TURP for this patient after the treatment of brachytherapy?
So immediately after brachytherapy, these patients have seeds in the prostate. The seeds kill off the cancer. By doing TURP, you remove some seeds, you alter the dosimetry, you alter the configuration and anatomy of your prostate, and you impair the cancer killing abilities and compromise on the patient's cancer treatment.
I understand.
All right, can we move on?
Yeah. Thank you.
Thank you. Okay, so this was my 94-year-old guy who he was voiding reasonably well. He went into retention, put in a catheter, removed it after a few days, went back into retention, tried again and again, went back into retention. At 94, shucks, limited options. I wasn't going to do a TURP on him. Spoke to him about a stent. He was in reasonable nick, and he was quite happy to sort of, go ahead with the stent. So I put in a suprapubic catheter at the same time as implantation of the stent. But you can see here on cystoscopy, his bladder was markedly trabeculated. And all right, if you look at his prostate, you can see the lobes were markedly occlusive as well. All right, I'm going to rush the next video. Can you guys hear the audio on my video?
Barely.
Okay, so I'm showing the one platform system there. I'm going to move on. I think we've spoken about it. You guys get to do it. Okay, so this is how I do it. With fluoroscopy, I mark the bladder neck, and I mark the verumontanum. Okay, and that's where I want the stent to sit. And yeah, this looks fantastic. This is a very high bladder neck, and you can see my prostate is this is all prostate over here. So my bladder is starting somewhere around over there. So once I've marked it, I kind of know where my stent's going to sit. And I also mark the sphincter as well. So I then, with fluoroscopy, will implant my stent. I'll show you on a subsequent. Okay, this is my. Okay, so this is me implanting the stent. So I basically, once I've done my marking, I fire my trigger at the bladder neck, and then I'm squeezing and releasing the stent. Okay, and all doing this under X-ray vision. And you can see right now, my stent basically is being deployed, and it's opening up quite nicely as well. All right, and okay, and so in the subsequent, in the X-ray on this side, I've already removed the device. Well, I'm showing you there. I'm removing the device. I'm coming through it very slowly as well. I don't want to dislodge it. And here on the right-hand side, I've removed my delivery device. And okay, this is I'm injecting contrast through it here. And let's just wait for the contrast. There we go. Okay, so I'm going to freeze that picture right there. So there's my injection of the contrast. There's my stent sitting within the prostatic urethra. That's my sphincter over here. And you can see, and there's a high bladder that we spoke about. And this is basically all prostate around all of this that's causing the occlusion. There's my stent, widely patent right now, sphincteric wire and the bulbar portion. This was a fantastic result, good placement. And this patient did very well. He was 94. He actually, shame, he passed away about 3 months ago, passed away with the stent and never needed a catheter or to see me again after that. Well, I mean, he saw me, but it was purely for social visits. He didn't have any issues with his urine after that. He even got through the first few weeks with flying colors. He didn't have much pain, and he was a very happy guy. Okay, so moving on from the TPS, the round posterior stent. These stents, basically in a nutshell, are meant for posterior urethral strictures. Commonly following a radical prostatectomy, bladder neck contractures. All right, and these stents come in basically two sizes, the 30 or the 40 millimeters. And if you look at it, that's basically where the stent would sit, across either your posterior urethral stricture from either an aggressive TURP, but more commonly from a bladder neck contracture following a radical P. The stent sits across your narrowing, again, like the TPS. It's got a sphincteric portion and an anchor that sits within the bulbar urethra. Okay, before you implant these stents, you'd have to dilate your stenosis or cut your stenosis or find some form to open up the stenosis to an adequate diameter. All right, my preference is to do it with the Collins knife. I've occasionally used a laser as well, but the laser can add a bit of cost to the procedure. The Collins knife is basically relatively inexpensive, and I get a good result across that as well. So you look at this, that's basically a bladder neck contracture right now. There you can see a bit clearer as well, which we opened up and placed the stent across it. Sorry, these are not my pictures, which was opened up rather, and a stent was placed across it. So I'm using these pictures to anatomically show you, how the stent sits and how it addresses these contractures. All right, again, it's a good option before reflexly condemning these patients to lifelong catheterization. And just like the TPS, it can be done under local anesthetic. Okay, so the first patient that I'm going to show you is a guy who had a bladder neck stricture following a TURP, and you can see we implanted a RPS stent across here, and he did very well. The second patient, very interesting case, and I just want to show you this to highlight some novel uses for the stent as well. This is an 84-year-old male who had prostate brachytherapy 10 years ago for prostate cancer, clearly. And he subsequently developed cancer of the rectum recently. And someone here missed the boat or missed the trick and decided that he was an ideal candidate for external beam radiation. And clearly, having had 2 forms of radiation within the pelvis, just about everything took a beating, and he developed a rectoprostatic fistulae. When he presented to us, he was having recurrent urinary tract infections. He was passing feces within the urine, and he had very poor quality of life. Was admitted for recurrent febrile UTIs, recurrent episodes of cystitis and prostatitis, and even upper tract infections as well. And shame, this poor guy was spending more time in hospital than out. So he's actually a patient managed by a colleague of mine. And we had a look at these x-rays together, and we decided to give him a chance of implanting a stent across this to occlude basically the fistula, just to allow the urine to keep the feces on one side and the urine on the other side. And the picture on the right-hand side is basically me going in with a scope and injecting contrast. And what I'm outlining here is basically the sigmoid and the rectum within the urethra. So, the contrast followed the path of least resistance. The big hole here was basically allowing all of this to go into the rectum and nothing in the bladder. And you can understand, sort of why this guy was in such poor shape. So what we did was we implanted the RPS across, and same patient, and I'm injecting right now, and there we're filling up the bladder, and we're not filling up the rectum. And I was going to say shockingly, well, not shockingly, this guy did very well. Once we sort of implanted the stent, I think he had a single episode of a UTI about 2 weeks after that. It might have been from the procedure itself. We admitted him, we kept the stent in, we obviously didn't interfere with the stent, we treated him, and we left him on prophylaxis for 3 months after that, didn't develop any subsequent UTIs after that, took him off the prophylaxis, followed him up for a period of, I think it was about 15 months, and he sadly demised after that as a consequence of his rectal CA. But we were quite proud of the fact that we gave this guy his life back. I mean, he wasn't admitted for a single UTI after this implantation of this device. Okay, so
I think we need to just to clarify something. So actually, you close the fistula using the RPS, yes?
No, I didn't close the fistula. We occluded the fistula. So we kept the. I suppose you could, but this guy didn't live long enough to see whether we could. We had closed it or not. I wasn't very optimistic that we could close this fistula because it was radiated tissue. Didn't think that any flaps or anything were going to help him. So the purpose of this exercise was just to occlude the fistula, and we could because this is a self-expanding stent. So basically what we did was we kept the urine flowing, through the stent, and we kept the feces flowing, and the stent basically kept the feces from on the sigmoid side and the rectal side, and stopped it from coming into the urethra, and it prevented him from getting infections after that.
Actually, if you leave the stent,
but we have, Sorry, Maxime, you were saying?
So if you leave the stent permanently, I don't see here leaking. So if you say it and replace it, for instance, so that will be no leaking, and therefore, even though fistula will be not like healed or closed, you can still occlude. You use it like a patch effect, exactly the way we do it with URS, and there is no leak.
So Maxime, coming back to your point, yes, and I think and Allium has now been it previously was off-label use in fistula, but now we've got indications of use in fistula, and yes, with the intention of cure. This patient, I used it purely to highlight the fact that, and I think you got to select your patients as well. I don't think this guy was ever going to be cured with any form of treatment, even if he was a healthy guy. He still was starting off on a hiding to nothing. He had radiated tissue, twice radiated tissue. Nothing, in our opinion, and I think the specialist here would concur with me. Nothing here was gonna fix that fistula. Anything. We're just setting ourselves up for a fail, and a massive fail at that as well. Any repair would have broken down. So with this guy, it was a stent that we put in palliatively to keep him well. But yes, to answer your question, yes, you can heal a fistula. Problem is that when you're dealing with fistulae in the lower urinary tract and using stents, I don't know if anyone's done a study, Maxi, maybe you can tell me, but you can't put an endpoint to it. And, at the end of 3 years, or you should be willing to take out the stent, reevaluate with contrast, at which stage either your fistula is closed, which is fantastic, you can leave the patient without a stent, or if not closed, you should get a much smaller fistula, in which instance I would suggest reimplanting the stent and then, sort of repeating the procedure in a few years. So, fistulae can be a bit of a hit and miss, they can be... But the good thing with these stents is that They're minimally invasive. It's not a huge procedure, very minimum mobility, and it's unlike the flaps and stuff that we would perform here. Yeah, sure, the flaps would be the definitive way of addressing this. But, you're often dealing with tissue that's been infected, tissue that's been radiated. And, I personally don't enjoy delving in these flaps because one procedure leads to another, which leads to another, and then you got breakdown. And then you end up involving, more and more disciplines, and to the point where you got general surgeons and plastic surgeons involved. And, no one's really bringing benefit to the patients. So, I think we also need to set out our objectives at the inception. We were very clear with this patient. We told him up front, we're not going to cure your fistula, but we'll get you in a better space. And we did that with this guy. And I was very happy with that outcome.
Yeah,
okay, I'm going to move on.
If I can patch it, so that's I think it's a good temporary solution. Another couple of questions for this specific case. Do not you afraid from erosion of the stent in such a tissue?
Sorry, Maxime, say that again.
What about like possible erosion of the stent for such a rotten tissue as you describe it?
Yeah, that's always a risk, especially with radiated tissue as well. But, the thing is that it's the justifiable risk, I would say. The radiated tissue is so unpredictable. You put a foreign body against it, especially under a little bit of tension, and, anything can happen. I wasn't too concerned about erosion in this guy because I got good tissue on either side of that fistula. So, did speak to him and tell him there's a possibility that we could get erosion, possibility we could make the fistula worse. But I mean, he already had a huge communication between the rectum and the prostate. And every time we scoped him, we made that hole bigger. So, it was a risk he was willing to take and a risk we were willing to offer him as well. So, yeah, back to your question. Yes, there's a risk of erosion, but, I didn't think it was significant in this case. Okay, can I move on?
The last question in this for this case. What I see is a black spot in the bladder. This is residual urine volume or just a contrast?
That's my contrast. That's me outlining that I'm in the bladder.
So they don't have a RPV on the high level. So it drains well, yeah?
Sorry, Maxime, I missed you. He doesn't have post-void. Is that what you're saying?
So the bladder is well drained. It's not like residual volume cannot be drained. Okay,
this picture that you're seeing right now is me having injected contrast. Right, there was a bit of air in the bladder. Obviously, with the fistula that he had, he would have had air in the bladder. So, I use this picture to outline that we're not seeing the rectum and the sigmoid anymore. We're outlining the bladder. This was a picture done on the table. It wasn't a picture done post-voiding. This guy was 84, so he did have some post-void, which is expected in an 84-year-old gentleman. And that's not because we haven't adequately addressed his outlet obstruction, but more because of the fact that he did have some detrusor decompensation.
I understand.
So, I can't recall what his post-void was, but it was acceptable for his age. But I'm not demonstrating post-void here. I'm demonstrating the fact that my contrast is outlining the bladder. All right, can I move on? Okay, just to basically talk about my ILM experience. I'm going to highlight some of the challenges that we face here in South Africa, which I think is probably challenges that most people face. And then, South Africa is quite a diverse medical infrastructure and medical system. We've got a first world private healthcare system and the public healthcare system, which I'd be loath to call third world, but it certainly isn't first world. So, there's a big gap between what our patients are sort of exposed to. A lot of our patients have limited access to theater time. I mean, I'm talking predominantly about the public sector. Also, the cost of medical treatment is always an issue, be it both in the private and public sector. And we're often practicing cost-effective medicine, but at the same time, quality, medicine, sort of, and striving for a compromise between the two. Patient compliance can be a huge issue in this country. You can carry out a procedure and inform the patient of the necessity and the need to follow up. And, I find myself, especially in private practice, often writing letters, informing patients that they haven't kept their appointments, which was necessary and essential for sort of, ongoing optimization of their health to prevent any sort of, complications. We've got lots of concomitant third world diseases in South Africa, things like tuberculosis, schistosomiasis. HIV is still a problem in South Africa. All right. Our patients often present late as well. So, unlike first world countries where your strictures will tend to be short segment, our patients will wait right until the end where they really can't walk anymore. They're to the point of collapsing before they present. So we see a lot of advanced pathology, which, you guys would know can be sometimes a bit more difficult to treat. And, a lot of our people, unfortunately, are still rural and they have very poor access to healthcare, which, explains the above points, through no fault of their own. Okay, so if you look at the benefits of the lower urinary tract stents in our setting, if you look at the benefit of the BUS stent, okay, so it's a viable alternative to repeated procedures. So already, it gives us, and by doing this, it's giving us definitive stricture management and not just sort of, temporary solution. All right. Okay, limited access to urethroplasty is not entirely true, but it's a specialized field at the same time, and I think it should be done in expert sort of hands. The BUS stent, by offering us a definitive stricture management solution, can alleviate our theater burden and reduce our waiting list. And long term, this has proven to be a cost-effective solution. If you look at the TPS and RPS stents, they're fairly simple procedures to carry out. They can be done under local anesthetic. I don't do it in the rooms, but it's been described. It clearly gives our high-risk patients the chance to void spontaneously and avoids a prolonged indwelling urethral suprapubic catheter. And, like we had a much sort of engaged discussion about, it is an option. I'm not suggesting that all your patients post-brachytherapy have it, but it is a viable option for a patient post-brachytherapy who has gone into urinary retention, in whom you previously would have left in an indwelling catheter until such time the oncologist said he's happy that the patient's cancer is under control and that the radiation is not an issue anymore, and then you can go forward and you can disobstruct that prostate surgically. So if you look at my IUM experience, ureteric IUMs I've now done over 150, and for a variety of indications. The two that I want to point out are our sort of, pet likes here in South Africa, bilharzia and tuberculosis, which I'm not sure if you guys in the rest of the world are seeing lots of that. We still see lots of this. Lots of bilharzia as well. I just put in a nephrostomy a few days ago for a patient who has bilharzia, and took him back today and sort of removed the nephrostomy and antegrade stented him. And the plan with him is he's got a tight stricture at the distal ureter. Plan with him is to put in an allium stent across that. And, it's our experience with these stents in bilharzia has been fantastic, and likewise tuberculosis as well. But those are upper urinary tract stents, and I thought I'll just touch on that, but that's not the scope of the talk. So the low urinary tracts, I've done quite a few as well, with the good success, I must say. The indications, especially for the BUS, have been recurrent urethral strictures, tight strictures, and long segment strictures. In the beginning, I used the shorter stents, but since then, my preference has been to use the reverse AT, purely because with the reverse AT, I get as close to the sphincter with 45 French apposition across the stricture, and not the 28 French on the tapered segment. And I find that strictures close to the bulbar urethra, the reverse BUS, gives me better long-term outcomes. The reverse BUS can be placed within a millimeter of the sphincter without impacting on continence too much. If you get too close to the sphincter and if you find that your patient is dribbling a bit, you don't have to necessarily jump in and go and remove, or rather pull the stent back immediately. I think just give the patient a few days, put him on Kegel exercises, and I've found that a lot of patients actually do settle with that. I've only had to pull back one stent in my time. Okay, just a few tips and tricks. Okay, I'm going to leave this here. I think these are technical things. I'm not going to waste time on that. All right. So if we look at the treatment options for urethral strictures, basically the allium stent, it's well tolerated by the patient. It's an outpatient procedure. Patients go home the same day. It is reversible. Once the stent is out, the patients will go back to basically as they would if they were having recurrent ureterotomies. It's got a high efficacy, works fairly well. It's a simple procedure and it's a short recovery time. If you look at the other forms of treatment, including a urethroplasty, I don't think we can tick all the boxes here. Patient comfort for urethroplasty, not the most comfortable procedure, especially with the indwelling catheter for weeks at a time. Definitely not an outpatient procedure. All right. It's not a simple procedure. The recovery time is certainly not short. Okay, if you look at my outcomes, the average age that I've operated on has been 44. My average stricture length has been 17, and got at least 3-year follow-up on some of these patients right now. These are my baseline parameters. My average Qmax starting off was 6.5 with a significant post-void of about 100 and IPSS score of 19. So when I compared my pre-op to my post-op, my Qmax on average went from 6 to 12.5. My post-void residual dropped from 110 to 45, and my patients had satisfaction as well. And just to tell you that this is the follow-ups that I have on these patients. 27 of these patients now have 3 years follow-up, and I'll look at this category specifically. The average flow rate in the patients that are 3-year post follow-up in my practice has been 15 mils per second. This is 3 years post follow-up. The average post void has crept up slightly to about 45 mils, but not anything that has raised alarm bells.
After stent removal, you mean after stent removal, this follow-up?
3 years after stent removal.
Okay. Okay.
All right. So I've had 6 stents migrating, 4 patients with significant pain. Most of them settle well after about 6 weeks. I think it's important you anticipate that and you adequately counsel your patients about this. Told you two of these patients had immediate significant stress urinary incontinence. A little bit of dribble will settle. In one of them, I had to pull the stent back. The other settled in day 3 with the Kegels. And there was only one patient in whom I had to actually move on and do a urethroplasty because the stent didn't work. So to summarize my BUS experience, the stents are fairly well tolerated. There's an acceptable complication rate. The follow-ups show subjective and objective improvement. The failure of the stent, in my experience, does not compromise tissue integrity for a subsequent urethroplasty. Overall, these stents are cost-effective, and they give our patients significant quality of life over the other forms of treatment options for urethral strictures. To summarize my TPS experience, again, I find these stents are well tolerated, again, with an acceptable complication rate, with good improvement post-insertion. Importantly, and I think this is where these stents would fit in first line, the high-risk patient who's in urinary retention. All right, again, they're cost-effective treatment options and give us a good quality of life improvement. And I think the same can be said with the RPS stents as well. So thanks, guys.
One question in regard of RPS, Dr. Amkison, if you mind. So we claim in Alliums that there is no other alternatives than RPS. Are you agree with this?
Maxime, sorry, say that again. I missed that.
Our statement in Allium that RPS is the only alternative for the bladder neck contraction. Are you agree with this, or you can consider other options?
So I would agree with you in that it's the only stent available for bladder neck, contractions. But I wouldn't agree that it's the only treatment option. I was in Spain about a year ago with my HOLEP guru, and they don't use stents for bladder neck contractions. They incise the bladder neck contraction with the laser, the same laser that they perform the HOLEP. He incises it in a Mercedes-Benz fashion, and he injects steroids into it. And he says he's got good long-term outcomes with that as well. So, to answer your question, I would agree that the Allium is the only stent, the only form of stent across the bladder neck. But yeah, there are treatment options as well. And I don't think anyone's done a direct comparison of a stent versus steroids. So, that may be coming, maybe something to look at as well. Okay, so just to summarize, and by no means am I saying surgical urethroplasty is rubbish or should be thrown away, but I'm saying that it is still considered the gold standard, but it's got issues associated with it, because if it was the panacea for urethral strictures, we wouldn't be looking at minimally invasive treatment options. And, the major limitations are the cost, the accessibility, the expertise, and for the patient, the prolonged hospitalization, the time of work. All right, so with the Allium stents, we're offering a minimally invasive treatment, and again, treatment option. We're managing these strictures. We are fixing these strictures long term. All right, we're not just repetitively offering the patient multiple endoscopic procedures as with repeated ureterotomies. We're giving them a definitive stricture management solution with limited morbidity and over the traditional open procedure, which in our setting significantly, it alleviates our theater burden, and long-term, these are definitely a cost-effective solution. All right, the TPS, again, it's reversible under local anesthetic. It can be carried out, gives our patients much improved quality of life over catheterization. And yeah, we've spoken about the brachytherapy ad nauseum. The RPS, again, it is the only stent that's available to insert across the bladder neck, gives our patients a solution for a bladder neck contracture, again, can be done under local and offers our patients quality of life. I'd like to thank all of you. I didn't realize it's been an hour. Again, sorry for the starting 3 minutes late. But yeah, I think once we got going, it seems to have gone fairly well. thank all of you for spending your evening or afternoon, wherever you are, with us, and for listening to this talk. I'm hoping that in some ways, sharing our experience with you will imprint and sort of, impart onto your practice, and offered you sort of, suggestions that you could take forward and sort of use from that. And I'm happy to answer questions. And Maxime, I know you will kick it off, so go for it.
Okay, so firstly, I would like to mention that the number of urethrotomies previously done for BUS stent implantation will also be worse for the results of urethroplasty, and also will affect not for good the BUS efficiency. So the less is better. Okay, so you make 2 urethrotomies, go for stent or go for urethroplasty. Don't continue. Just continuously cutting the flesh. Okay. You agree with me, Dr. Amkinson?
No, absolutely, and that's been proven in that Coachella series as well. I hope the guys are on. Fantastic guys. Yeah, that was so. Basically, they in their paper, they've put in writing what we've always known and what's pretty obvious, and gives us some guidelines by which to go to as well. I think if you anticipate your patient's got a troublesome stricture, then implant the BUS earlier rather than later, because your outcomes, you get better outcomes with the fewer urethrotomies that you do. Absolutely agree.
Okay, I will tell you a very nice story, about the BUS. Not far ago, it's like 5 months ago, we had a patient in former CIS, the region. The block of the 8-ton weight, he was working in the port. So, and the block of 8 ton just was dropped on his penis, from the height. So have some breakdown of the bones, some bones debris. His urethra was crushed, so he underwent the reconstructive surgery, urethroplasty, and then he developed the stricture. So actually, the stricture started from the very close to the sphincter, unless in the sphincter, and we decided to implant a BUS to this patient. We implanted not a reverse because it was not registered in this country, no regulation. So the normal BUS of 8 centimeter, and it was like 5 months ago. So it's very nice story because not far ago, the doctor contacted me and he says the guy's urinated nicely, all is fine, the stent remains for 5 months. So I was very happy and just wanted to share with you this interesting case.
Yeah, thanks for that, Maxime. So, you and I spoke a while ago, and I'm just going to basically spend 10 seconds talking about this because probably outside the scope of this talk, and I don't want to bore everybody else. But I did suggest to you that we could offer you a trial here in South Africa for implantation of a BUS across a urethra that's been acutely traumatized, as opposed to leaving in a urethral catheter, waiting for primary realignment, and then dealing with the subsequent stricture. The proposal was that we could get that realignment done with the BUS across the traumatized urethra or the severed urethra or the disrupted urethra, and allow it to heal. And after removal, allow it to heal around a 45 French lumen so that there will be no subsequent strictures left to deal with. So that's something I think that, should be looked at.
Yeah, this also reflected in the very good publication of Professor Moon. He also compared Memocat with Allium for the complete urethral rupture of the bulbar urethra. So it was primary realignment, then the Allium stent or Memocat stent was placed for like half a year, then removed and investigated. So also very nice results, also reflected in Allium BUS card. We have a table comparison of the results between 2 stents. So I finished with my questions, and I just want to give a room for the others.
Okay, while we're waiting for input from the others, I just had a look at the audience and the participants that are on, and I see that I would like to thank the South African community. Yeah, lots of my colleagues, especially my colleagues from industry, have joined. Thanks guys, thanks for the support. I think you guys are tired of hearing my voice, and I noticed that. And sorry, I'm gonna spend 2 seconds here giving some airtime. That my wife is on this webinar as well, and which is a bit surprising because she's actually got a meeting within her own discipline that's running concurrently as well, and I'm pretty convinced she's listening to me and not the other meeting. So thanks, babe. I appreciate the support. Anyway, I'm taking questions now.
I would like to ask something. For the prostate stent, are you doing any kind of measurements of the prostate, not just using the finger, but I don't know, ultrasound or something, or do you just go inside and check the length before you place the stent?
Okay, are you talking about the pre-op measurement, Shay?
Yes. So
Yeah, so
do you
preoperatively,
use it?
routinely, these patients get ultrasonic assessments of the volume of the prostate. But the important point is, and I'm going to stress this as well, that the size of the stent, and I think that's where you're heading with this question, the size of the stent that you implant is an intraoperative call. You know, your measurements, in my experience, even on CT, doesn't always translate into that accurate length between the bladder neck and the verum montanum. And it is an intraoperative call. And, my support base here from industry, who sort of distributes the stents here in South Africa, will often tell you that when I'm doing a prostatic stent, I suppose they won't openly sort of confess to it, but I'm sure it annoys them because I don't give them a size. I'll tell them, please have, and I'll tell them, if it's a smallish prostate, a 30 or a 40, or it's an intermediate size, depending on whether it's erring on the side of small or big, but I'll tell them, please have treatment options for me. And I'll give them at least two sizes because the final decision is made intra-op when I measure the length from the bladder neck to the veru. But to answer your question, yes, before I take these patients to theater, I have an idea as to the prostate volume. If the patient's got a CT, I kind of get a crude measurement from bladder neck to veru, but the final call is made with my cystoscopy or the measurements taken intra-op.
This is part of what I asked. So this is, of course, how do you select the final stent at the end. But will you have some kind of, let's say, upper limit? You can have a 4 centimeter stent or area that you need to place the stent, but maybe it's for 40 gram of prostate and maybe for 80 or 100. Is that do you take that into consideration in some way?
Yeah, you're talking about the size of the prostate.
The volume.
Yes.
Yeah, so
The
that's where I probably would ask you guys. To my knowledge, it's 120 grams. I haven't put a stent across anything that big. I think the biggest I've done is about 80 grams. Does the manufacturer have an upper limit as to what you would sort of limit or sort of recommend that beyond this, maybe don't use the stent?
Yeah, we use the 80 gram number, but I have to say it's I don't know if it's half experience, half guessing, half whatever. It's not very scientific. So
Okay,
this is the reason why I asked.
Yeah, so from my experience, what I would advise is, and remember, with these TPS stents, these are patients, it's last chance saloon, So I would suggest that if you can get a stent from the bladder neck to the verum montanum, with good coverage of the prostatic fossa, then you're not really guided by the size of the prostate because the enlargement is often symmetrical. We can get a 120 gram prostate, but a 4 centimeter urethra. When sometimes you can get a 80 gram prostate with a 6 centimeter measurement from the bladder neck to the verum montanum. So the size of the prostate, it can be a little bit of a hit and miss. It's more the length, the length of the occlusive prostate, that would impact on your decision as to whether you can successfully get a stent across it or not. So I would keep it as an intraoperative tool. If I feel that I can't get good coverage with the stent across that occlusive segment, then I would pull the plug and I'll bail on it. But if I feel like I could, then even if the prostate weighed 120 grams, I would give it a shot of implantation because I think it would be successful. I haven't done 120. The biggest I've done is 80.
Okay, thank you.
I think we're on the same page, more or less. By the way, Dr. Ankinson always invites, and I think it's also important to share with the audience. A long time ago, we advised that we will make a workshop in Durban, in South Africa.
Yeah, our next international workshop is not going to be in Coachella. It's going to be here in Durban. So you can start working towards that. Now, we did a nice workshop with Maxime as the only invited attendee and guest and participant last year.
Oh, and, yes.
We had a great time and we learned a lot, yeah.
We have a lot of cases of value.
But you guys are welcome. I'd like to invite and open up our center. We run a nice academic unit here. We do a lot of allium stents. We teach a lot. We do a lot of webinars and broadcast a lot nationally when we're doing these procedures as well. So if any of our international delegates want to spend some time with us, you're more than welcome.
One day we have a training and stent implantation. One day we have safari. Okay, if it doesn't sound very attractive to you, I don't know what
No,
would
that's
be attractive.
absolutely, yeah. There's something for Shay to work towards here. Okay, are there any other questions? Can we wind up? Okay,
Yes.
Maxime, thank you again for this opportunity. It's been wonderful as always. Enjoy touching base with you guys. Enjoy speaking on the product. Enjoy imparting knowledge and my experience. I'm going to leave you to round up and to close the meeting. So thank you again for this opportunity,
I will
guys.
just thank you for this very practical, very important, very useful webinar. We had 30 people on top, more than 30 actually, during your session. It's a big number of participants. Thank you very much. Thank you for your time. Thank you for joining.
It's a pleasure.
For sharing.